3 times faster than physician and clinical services since 2000. So in the last 18 years, prescription drug prices have risen 3 times faster than physician services and clinical services. And we pay the highest prices in the world. Outrageous prices force people in my home state of Michigan and across the country to skip doses, split pills in half, and even go without the medication they need. And we know that this is a matter of life and death for too many people. I want to give just one example in my opening comments. The outrageous price of the opioid reversal drug naloxone. Now, if someone is in an overdose, naloxone in some form is used by emergency room physicians, by first responders, by police officers in order to save people's lives, literally save their lives. This particular drug was approved by the FDA in 1971. So it's gone through its patent, long off patent, 1971. Generic versions have been available since 1985. And in 2005, a generic vial of naloxone cost about $1. So one vial cost about $1 in 2005. And then what happened? By 2013, the generic drug was being sold for 15 times more. And Evzoa, a naloxone auto-injector, now sells for more than $4,000 for a 2-pack. And Narcan, which is the most commonly used form of naloxone, it's a nasal spray version of the drug, is sold for $150 for a 2-pack. Now we, as taxpayers, fund local law enforcement, fund emergency rooms and others to pay that price of something that used to be about $1. So, as the need went up, as we had an opioid crisis, the price kept going up and up. We're here because we believe healthcare is a basic human right. Unfortunately, our Republican colleagues believe it's a commodity to go to the highest bidder. And to add insult to injury, the American people, through our tax dollars, all of us together, fund basic research and development that leads to many of the new drugs and cures on the market. So we fund, which I strongly support, the National Institute of Health, doing basic research that is frankly too risky for a private company to do. But once we get that information, they're then able to take it and develop it, and then we allow them a write-off on their taxes, so we contribute again. And then we give a patent, usually about 12 years, so that they can recover their costs by not having competition from a generic drug. And then, in the end, all we ask, and I believe American taxpayers deserve, the best price that we can get, because we have helped and supported the development of these medications. And to add insult to injury again, right now, Big Pharma was a huge winner in the Republican tax giveaway because they have been able to put $50 billion from that tax giveaway into the pockets of their CEOs and their investors through stock buybacks. But the last time I looked, I didn't see one price go down. One price go down on prescription drugs. Again, Democrats believe that healthcare is a basic human right, and that includes the ability for you to afford your medicine. We're taking the lead on critical policies to bring prices down, and with your voices and your help, we can take on the lobbyists and get this done. This includes allowing Medicare to use its group purchasing power to negotiate the lowest prices. It's time to harness the bargaining power of 41 million American seniors. We need to bring transparency to the system so that drug companies are held accountable for the prices they set and consumers know that they are getting the lowest possible price. We need to make sure that our pharmacist can tell you if you can get a lower price out of pocket rather than your copay from your insurance, which is legislation that I'm leading as well. We also need to make sure your insurance covers the drugs you need. The expansion of short-term and association health plans, along with a court case brought by 20 Republican-led states, attorney generals, and governors, could mean that insurance companies no longer have to cover prescription drugs. And right now, our federal government should be taking on that case and pushing back on the people's side, and this administration has refused to take the case on behalf of the American people. So I could go on and on. I will not. We want to hear from all of you, and I want to hear from colleagues as well. This is a very, very important subject that we are committed to working with you to address in every which way that we can. I want to first turn to Senator Ron Wyden, who is our lead on the Finance Committee, the ranking member on the Finance Committee. He does a terrific job. He's really been focused in a number of areas, including transparency issues that are so very important, and we're very appreciative of Senator Wyden's leadership.
Senator Stabenow, thank you very much for putting together today's hearing. I want to welcome all our guests. I'm going to be mercifully brief. I do want to note the fact that Senator Stabenow is the ranking Democrat on our important health care subcommittee, where she has really been our lead in terms of fighting for seniors and holding down the costs of pharmaceuticals. Now, 2 years ago, when then candidate Donald Trump was on the campaign trail, he said that he would make sure Medicare would negotiate like crazy to hold down costs for seniors and taxpayers. As of now, well over a year and a half into his term, most Americans believe it is crazy that we are still not negotiating to hold down the costs of medicine. Now, the president made another array of really remarkable statements. He said that he would get prices to drop dramatically. His words, not mine. We all know that what we've gotten instead was a lot of public relations mumbo-jumbo instead of concrete steps. And I want to put this into context because we feel very strongly that we need to play offense and come up with real approaches that hold down the costs of medicine rather than all this public relations choreography. It almost sounds like he's trying to schedule an Olympics, but nobody ever gets to show up. No athletes get to show up. It's just all fanfare and hullabaloo. So in addition to making sure that we can lift this ridiculous restriction so that Medicare could bargain, I have introduced a proposal that caps the out-of-pocket costs for medicine. Senator Stabenow has put in a wonderful transparency bill to make sure that when you're in the pharmacy, you can have a chance to get a reasonably priced drug. And I've also introduced something called the Spike Act, which would force the pharmaceutical companies to justify these huge price hikes. And we've included a version of that in our Better Deal proposal. Now, what Spike says is that the Department of Health and Human Services, when drugs increase by more than 50% or over 5 years or 15% in a year, the pharmaceutical companies would have to explain the increases. So that gets right to a valuable point Senator Stabenow made. Are they spending the money on critical research and development, or are they just spending it on ads and all the rest? So I'll close with just a couple of examples of what Spike would mean right now for all of you and consumers. Pfizer would be on the hook to tell the federal government and the public why its nerve and muscle pain drug Lyrica, why the price has increased 127% over the last 5 years. Medicare spent $2.1 billion on this drug in 2016 alone. So if Pfizer and the Trump administration want to brag about all the steps they're taking to address drug prices, in my view, a better place to start would be justifying why seniors and taxpayers have had to absorb a triple-digit price increase on one of Medicare's most used drugs. I'm going to put into what we call around here, put it into our kind of record, because we had the same thing happening with Crestor, a drug for high cholesterol. We have the same thing happening with Lantus, an insulin product from Sanofi. But the point is, what we want is more than PR that really isn't changing anything for people at the pharmacy window across the country. We want measures that have teeth, that are enforceable. They're going to make a real difference for the consumer. Senator Stabenow, thank you for what you're doing, and look forward to working with you and our colleagues.
Thank you very much, Senator Wyden. And we're now going to introduce our witnesses. Thank you so much. And I have both Senator Van Hollen and Senator Smith who are here, and they will be introducing special people from their states as part of our introduction. So let me start with Mr. John Glazer. Thank you so much. We're going to just introduce everybody, and then we'll come back to you to give an opening statement. Mr. Glazer is a retired social worker who lives in Alexandria, Virginia. Retired a few years ago after 18 years as a grassroots organizer with the National Committee to Preserve Social Security and Medicare. And we'll let you speak about your prescription drug costs under Medicare, and we appreciate very much your being here. I want to turn now to Senator Van Hollen from Maryland to introduce our next witness.
Well, thank you, Senator Stabenow. I do want to start by thanking Senator Stabenow for bringing us together under the auspices of the Democratic Policy Committee and the work that she's done in her other committees, and we need to focus on this issue of affordable health care. And do it with the determination to not just talk about it, as Senator Wyden mentioned, but to put in place these very specific proposals that our colleagues have put forward, and I support. I want to thank Senator Wyden as well for his leadership, and Senator Smith, the new member, has really hit the ground running here. Thank all of you for being here to testify. We have a lot of very talented people in the state of Maryland who have been testifying on different healthcare issues. And today I'm really pleased to introduce somebody who's really been a very good friend of mine, someone who's been very active in our community, had a very successful and distinguished career, and that's Stahis Panagidis. And 3 years ago, Mr. Panagidis realized he had Parkinson's disease. And today he will tell us his story about how somebody who thought that they had a health care plan that protected them against these outrageous spikes in prescription drugs, it turned out that after all, the protection wasn't there. And we've captured it very well in your opening statements. It is just an outrageous situation when you have this huge tax windfall going to prescription drug companies, and instead of using that to help make prescription drugs more affordable, it's simply going into the pocket of their executives. And so we need to change that. The good news is we can change it, but we can only change it if we have a majority votes to get it done. So thank you for being here.
Thank you very, very much. And it is true, as we do our hearings and through the policy committee, we've had wonderful people come join us from Maryland and Virginia. I'm not sure why that is. I think it's because you're so close, right? I think so. But in addition to wonderful people, we have many wonderful people. So, but thank you, Senator Van Hollen, for many hats you wear that are very, very important, and certainly your passion for healthcare. Marquez Jones, Mr. Jones, we're glad you made it. We understand that you were caught in all the traffic and the rain, and you made it just in time. So welcome. We're glad to have you from Richmond, Virginia. Again, we are Virginian. He was diagnosed with multiple sclerosis in 2008. We Appreciate your sharing your story. It's my understanding that you're taking a drug with a price tag of about $75,000 a year. That's a pretty hefty price tag, and you've become a vocal advocate for those with chronic illnesses and diseases. And thank you for turning your own situation into action and advocacy. We're very appreciative that you're here today. I want to turn now to Senator Smith, who is our newest member, but certainly has, as Senator Van Hollen has said, has really hit the ground running from another great M state of, Minnesota, and she brings her experiences as a legislative. Sorry, you're the odd man out here.
Story of my life.
3 M's and an O.
3 M's and an O, that's right. But we appreciate your bringing your experiences from Minnesota and really being such a wonderful advocate on healthcare.
Well, thank you so much, Senator Stabenow, and to my colleagues. And I've had an opportunity to dig into these issues serving on the HELP committee, where ranking member Senator Murray has done a lot of work on this with all of us. So it's wonderful to be here, and I'm especially pleased to be able to introduce Nicole Smith-Holt, and want to also just acknowledge James, Nicole's husband, who is here. We first got to know each other a couple of months ago when I read about your story and the story of your son, Alec, and the experience that you had finding out that in this country, somebody literally, your own child, could literally lose his life because couldn't afford the medicine that he needed to stay alive. And as a mother of 2 sons myself, I tried to think about how I would grapple with that. And I want to just say to you that everybody's stories are so powerful. Your experience and then how you have turned that experience into being an advocate for healthcare as a right is really inspiring to me and gets me up every morning when I'm not exactly sure what we're going to do to make a big difference here. I am inspired to know that we have to make a difference. So thank you so much, Nicole, for being here to tell your story.
Thank you very much. And last but certainly not least, Lee Purvis. Lee is the Director of Health Services Research at AARP, Public Policy Institute. She leads a team of policy analysts and researchers who work on healthcare issues and heads the Institute's work on prescription drug and mental health issues. Her primary areas of expertise are prescription drug pricing, biologic drugs, and prescription drug coverage under Medicare. She's also the co-author of Public Policy Institute's annual RX Price Watch reports, which track price trends for prescription drugs widely used by older Americans. So thank you for coming with your wealth of knowledge and experience to be a part of our panel. So we'll ask Mr. John Glaser at this point to share your thoughts with us. And again, welcome.
Thank you, Senator. Thank you very much. I'm John Glaser, and along with my friends in the audience wearing the yellow T-shirts right behind me there are some of our best volunteers. I serve now as a volunteer with the National Committee to Preserve Social Security and Medicare. I've been retired for over a year now and haven't been enrolled in Medicare Part A for 14 years and in Part B and D since I retired. Being reasonably healthy, I have only needed to use a few of the Medicare benefits improved by the Affordable Care Act, but they've made one huge difference in my life for sure. The prescription drug benefits I receive from Medicare are invaluable to the quality of my life. I'm currently in what they call the initial coverage stage. I have not yet reached the coverage gap, or donut hole as it's known, as of the end of July. I have about $2,900 to go yet, so fortunately, I don't expect to get there before the end of the year. Well, I don't think I will spend enough on prescription drugs this year to reach the donut hole. I fell into the coverage gap last year. By September 2017, when I got out of the donut hole, I was paying 5% for most of my drugs, and that's not a bad deal. Because the Affordable Care Act is closing the donut hole, last year I saved about $2,000 on my prescription drug costs. But if the ACA was repealed, I would have had to pay all of my drug costs in the coverage gap last year, which would amount to about $4,371 a year. That would add up to a lot of money, particularly if I had an illness that meant I needed more prescription drugs and tests. Now, when you're living on a fixed income, as you all know, in retirement, you have to closely watch your expenses. If my expenses spiked, I'd have to think about cutting back on what I could spend on some of the pleasures in life that we all like to do, which is going out for a meal once in a while or seeing a movie. I know seniors who have had a harder time than me making ends meet. My brother Fred, for example, he has type 2 diabetes, lots of health issues. He has heart problems, and he's had a kidney transplant. And if you can believe it or not, he takes over 50 pills daily. 50 pills daily. He lives in a nice house. If he had to pay the full price for all those pills, he'd be living on the street or probably living with me. So it's incredible to think that somebody can take that many pills, but it's fortunately the prescription drug programs cover that to a large percentage. The Affordable Care Act has been a good thing for me and for my brother and other seniors. That's why the loss of Medicare drug benefit improvements through the repeal of the health care law would be so harmful to many of us. It should not happen. Thank you.
Thank you very much. I also want to acknowledge that Senator Dick Durbin from Illinois has joined us. Thank you so much, Senator Durbin. And Mr. Panagiotis, did I say that? I'm sorry, did I say that right? Panagiotis.
With some Greek accent.
Thank you. All right. Second time's a charm. Okay.
Senator Stabenow, I'm delighted to be here, especially pleased to see my senator and friend, Chris Van Hollen. I hope my Greek accent will not make difficult my remarks to you. Also because of my Parkinson's, my voice is usually suffering from hypophony. My name is Takis Panagidis. I'm an 80-year-old old man that worked for many years at the World Bank, the Organization of American States, the Ford Foundation, and other private sector companies. From 2005 to 2011, I served as the resident country director of the Millennium Challenge Corporation, MCC, in the Republic of Cape Verde. I have devoted my career to serving the interests of people everywhere, and especially of this country that I love. I am proud of my service. I'm proud of my family, my 3 children, my 5 grandchildren, and my very nice wife, Joy, who is here, of 54 years. She kept me for 54 years. 3 years ago, I was diagnosed with Parkinson's, a disease that, as you know, has no known cure. The effects of the disease can be mitigated through a combination of medicines. I'm grateful for the innovations that made this possible, even though if the result of the innovations are medicines that are a price you cannot afford, is no use. A few months ago, my neurologist recommended the new drug retiree, that's R-Y-T-A-R-Y, an extended release medication approved by the FDA in 2015. I was shocked to learn that it would cost me $400 plus a month, close to $5,000 a year, to have this medicine. Retiree was a medication my doctor felt I should take for best treatment, but I had to reject the possibility of taking it entirely because I could not afford it. So I gave it up. I did not accept this medicine. In my case, I have a robust medical insurance, Medicare A and B, supplemental coverage through the Mutual of Omaha of nearly $4,300 a year, in addition to Express Scripts. So in my case, I have all the insurance that one can have. It never occurred to me that even with this insurance and expense for premiums, I would not be able to afford the medications I need. Yet today, at 80 years old, I cannot afford the course of treatment that my doctor recommends because of the cost of the medicines. That's why I'm so grateful for a committee like yours that are seeking to give us better prices, and legislation that would allow Medicare to negotiate for more affordable drug prices, and hope the Congress will fight to bring a real change. Because, as I said, if people like me have difficulty, many more people have difficulty, even worse. Thank you so much.
Thank you very much. We're so pleased you're here and that your wife is here with you. Welcome. So, Mr. Jones, very pleased to have you with us.
I'd like to thank the committee for this opportunity. My name is Marcus Jones, and I'm the owner of a small home care business in Richmond, Virginia. In 2008, I sat on an exam table with my wife, Jessie, holding my hand, my grandmother and mother-in-law in the room, and at 27 years old, a neurologist walked in and said, "You have multiple sclerosis." This diagnosis changed my life. There were days that I didn't know if I'd be able to teach my then 2-month-old daughter how to shoot a jump shot, or if I would be able to walk her down the aisle on her wedding day. All of this came to a head one night at 2 a.m. I woke Jessie up and asked her if she wanted a divorce. I said, "You're 25 years old. You didn't sign up to take care of me for the next 50 years. She told me to quit acting dumb, rolled over, and went right back to sleep. From that day on, I was determined to do everything I could to be there for her and my daughter. I was prescribed the MS disease modifying therapy, or DMT, Avonex, and it worked wonders. Gone were the fatigue, headaches, and numbness I was experiencing. My energy returned, and my neurologist was thrilled to inform me that my disease progression had ground to a halt. When Avonex was first approved in 1996, it cost a little under $10,000. By 2017, it had increased to about $75,000. The medication itself has not changed, just the price. I have friends whose insurance requires them to pay between 20 and 40% co-insurance on their MS-DMT, forcing them to pay thousands of dollars per month out of pocket. In real terms, I could be paying more than $1,000 each month just for my DMT. So far, I've been fortunate not to encounter significant barriers accessing my MS-DMT. But MS is unpredictable, and I could experience an exacerbation or progression at any point that could take me out of the workforce. Or Avonex could stop working for me, and my healthcare provider and I will need to try a different medication. There are more than a dozen medications to treat relapsing MS, but the next medication my doctor thinks is best may not be covered under my insurance. Or they could want me to fail on other medications first. Can you imagine telling someone that they have to get worse and risk irreversible disease progression before getting the medication they and their doctor thinks will work best? This happens more often than we think with current step therapy policies. MS is a chronic condition, so my family and I will have to bear the cost of my DMT for a long time to come. My wife has arthritis, another very expensive condition to manage. So despite both of us being working, responsible adults, our healthcare costs are tremendous and our long-term health is unknown. These are realities that we live with every day and cause us anxiety and concern as a family. Since being diagnosed with MS, I've become an activist with the National MS Society. The Society has comprehensive recommendations and supports a slate of legislation to make medications more affordable and the process for getting them simple and transparent. The drug supply chain is complex and improvements are needed across the system. I urge Congress to consider solutions like those supported by the Society: transparency around drug price increases, transparency for pharmacy benefit managers, instituting electronic prior authorization in Medicare, common sense step therapy, discouraging anti-competitive tactics, and eliminating the PBM gag clause. You have the power to change the lives of those of us with multiple sclerosis who depend on these drugs. I ask for your support today.
Thank you so much, and appreciate your list of very important policy priorities. One good news on the gag clause, we've been able to move things forward. bill that I have in the Finance Committee and another bipartisan bill in the Help Committee. We are moving forward, but we're going to need help from you and from everyone to be able to get that through so we can stop those gag clauses and people can know what the lowest price is at the pharmacy counter. So thank you. Ms. Nicole Smith-Holt, we very much appreciate your being here.
Thank you.
And what wonderful pictures of your son that you have to share. Thank you.
Well, thank you, Chairwoman, ranking members, and members of the committee for allowing me to join you today to talk about the current crisis our country is facing concerning prescription drug prices. I am the mother of Alex Smith. My son Alec was just 24 years old when he fell ill and was diagnosed with type 1 diabetes. Type 1 diabetes is an autoimmune disease. It affects more than 1.25 million Americans, and is estimated that 40,000 people are newly diagnosed each year in the U.S. Type 1 does not discriminate. It knows no color, no gender, no age, no religion, no socioeconomic class. It doesn't matter if you lead a healthy lifestyle or not. No one is immune to the diagnosis, and it cannot be prevented. My son Alec was a healthy, active, hardworking young man. He tried not to allow diabetes to control his life, but he took control of his diabetes. The one aspect that he had no control over, and neither do the other millions of diabetics, is the cost of their life-sustaining insulin and diabetic supplies. It is reported that 1 in 4 diabetics have been forced to ration their insulin at some point. Rationing is extremely dangerous because if a person with type 1 does not have enough insulin in their system, their body starts to shut down. Rationing insulin is what took my son's life on that horrible day of June 27th, 2017. I received a call that no parent ever wants to receive or expects to receive. I was told that my son was found dead in his apartment on his bedroom floor. He was found all alone. My son aged off of my health insurance on June 1st of 2017 because he turned 26. He went to the pharmacy on or around the 22nd of June and was told that his bill was $1,300 for his monthly insulin supply. That bill includes 5 pens and his diabetic supplies. Unfortunately, Alec was a week from payday, so he did not have what was needed to pay the $1,300 bill. And so he did what many diabetics have done in the past. He began to ration what he had left, and he was found 3 days before his paycheck. My story is not so different from what I hear from other families. Far too many times I've heard of people resorting to buying insulin from the black market, swapping supplies from Facebook support groups, using expired insulin in test strips, trading sex for insulin, using pet insulin, starving themselves to reduce the number of units that they need, not paying their rent, rationing or skipping dosages, this allowing themselves only enough insulin to not die. Basically, millions of people with diabetes are playing Russian roulette with their lives. Parents are selling their homes, cashing in on their retirement and college funds, working 2 and 3 jobs, and selling their plasma. Young adults are dropping out of college. They're getting married just to have insurance, or not getting married to the love of their lives because they'll lose their state-funded insurance. I've heard of people with diabetes traveling to other countries to get their insulin. Some have even relocated to these countries. Many report stockpiling supplies and insulin, even expired insulin, just in case, because no one knows what the price of insulin is going to be next month. Some are even basically planning their own funerals because they cannot continue to pay the price of insulin. Insulin was created almost 100 years ago. Prior to that, the diagnosis of type 1 was a certain death sentence. The creation of insulin was amazing and saved so many lives. But here we are in 2018 and facing a death sentence once again because the cost of the life-saving medication is priced out of reach for far too many. Since 1996, there have been no real formulary improvements to the insulin product, yet the price has increased approximately 1,200%, and we have had no justification presented to us to explain the increase. If we look at the standard rate of inflation, in 1996, a vial of insulin that sold for $21 Today, with inflation, that vial of insulin should cost no more than $34. Without laws in place to prevent pharma from yet more increases, we will continue to hear of diabetics resorting to dangerous workarounds to prolong their lives. These workarounds are often deadly, and Alec is not the only one who has paid the ultimate price. And Tavia Lee Worsham, Shane Patrick Boyle, and Celie Weatherall have also recently died from the high price of insulin, and that's just to name a few. In the United States, healthcare is looked at as a privilege instead of a right. The rest of the developed world believes that we have a right to affordable and accessible healthcare, and we have a right to affordable and accessible insulin and medications. The World Health Organization has deemed insulin as an essential medication, and every other industrialized nation recognizes this except for the US. Why is it that we allow pharma and health insurance companies and pharmacy benefit managers to run our healthcare system? Is it because of the many millions of dollars that they spend each year by lobbying and buying our politicians? Why are we allowing them to police themselves? Why are they given the freedom to decide who lives and dies? This happens because no one is forcing them to have transparency. No one is forcing them to have caps on list prices. No one is forcing them to allow for a generic creation. They stand there untouched by the laws and are making billions in profits while those who struggle to afford their medications suffer and die. Many will say that these companies offer assistance programs. Let me tell you about these programs from my experience. They have very long wait times, lots of paperwork that needs to be completed by patients, doctors, and pharmacists. And very few actually qualify for those because of income limits. These are nothing but hurdles and barriers for patients. A diabetic can only live 1 to 2 days without insulin, and these programs take weeks or months to be approved. My concern is that they are creating these barriers as PR stunts to show that they care, rather than simply lowering the price. Why should a person who requires a medication to live have to use a charity program or beg manufacturers for help? Why not just make your medication affordable for all? In my eyes, if you have to offer these charity programs, helplines, and patient assistance programs, your company is fully aware that your product is too expensive. My response is lower the list price. Far too many Americans have high deductible plans and no coverage at all, so they are paying a very high price every single month to stay alive. Approximately 57% of people use insulin are subject to paying list price at some point. Some will say that there is a $25 insulin at Walmart. Yeah, Walmart sells insulin for $25. It's an older version, it's less effective, more difficult to manage, and is bought without a prescription, which means your physician is not assisting you with the management of it. This insulin is linked to loss of vision, loss of limbs, kidney failure, coma, and even death. The insulin reacts very differently than the insulin that most people are used to and causes more dangerous highs and lows. Physicians have a very difficult time trying to calculate the correct dosage for patients, so it is a guessing game on how many units the patient should be using, and they will need to test their blood sugars much more often. That means that they'll need to spend more money on test strips, money they don't have. Telling people to take this older, less expensive insulin is creating a two-tier system that allows for those who have money to get the best product and those who have lower income be forced to use the harder to manage, less effective, more dangerous product. I am an advocate for T1 International, and we are advocating for accessible and affordable insulin for all diabetics. Our advocacy group is free from pharma funding, and we need your support to stop the greed, to put a stop to price gouging. Big pharma should not be allowed to put a price tag on our lives, and we need for you to create and pass laws that protect us all from a certain death of corporate greed. And we ask that you to stand by our advocacy programs who are not taking funding from pharma. There are many organizations out there who have their own agendas and say they're supporting diabetics when a major portion of their funding is coming directly from the ones who have killed my son. Our family and friends have paid the ultimate sacrifice in this healthcare crisis, and we lost an amazing young man. He had so many hopes and dreams, and he left behind a 5-year-old daughter who now has to grow up without her father. His little brother lost his idol, and his sisters lost his best friend. My husband and myself lost our child. I want this crisis to come to an end. I want no other family to experience this great pain and loss. This should not have happened, and I am counting on you all to help me make sure this does not happen to another family. Please remember Alec, and remember the regular insulin injections is used to keep a person with type 1 diabetes alive. It is truly like oxygen. Please don't let pharma companies continue to price gouge oxygen for people with type 1 diabetes. Thank you.
Thank you, Nicole, very much. It means a lot that you're here. And we're so very sorry about what happened. You're right. In the United States of America, this should never have happened. And that's why we're here, because we're committed to doing everything we can to stop it from happening. Lee Purvis, thank you.
Good afternoon, Senator Stabenow and members of the committee. I want to thank you for the opportunity to be here today. I'd like to start off with some background on why AARP focuses on prescription drugs. Quite simply, it's the prices. A bit of historical perspective. About 30 years ago, there was a great deal of public outrage over a drug that cost $10,000 per year. We now have drugs with prices approaching $1 million per year. In other words, we have gone from drugs with one-year prices that are equivalent to a small car, which some may say is already too much, to drugs with prices that are equivalent to a 3,000 square foot house here in the DC area. Increasing drug prices affect older Americans particularly hard. Most Medicare beneficiaries live on relatively modest incomes. The median income is just over $26,000 and 1/4 of incomes of just over $15,000. They also have limited financial resources. 1/4 have less than $15,000 in savings. In other words, this is not a population that has the resources to absorb high and growing prescription drug prices. AARP is also concerned that the prices that we're seeing now are just the tip of the proverbial iceberg. High-priced specialty drug approvals have exceeded traditional drug approvals every year since 2010, and the number of people using such drugs is growing. Meanwhile, the research pipeline is full of products that will undoubtedly command even higher prices in what appears to be a never-ending race to the top. As if all of this weren't bad enough, the prices of prescription drugs often continue to grow after they come on the market. A recent AARP Public Policy Institute RX Price Watch report found that the average annual price increases for nearly 800 widely used prescription drugs was more than 50 times higher than the rate of general inflation in 2015. This finding is not new. The average annual price increases for these same products has exceeded the corresponding rate of inflation every year since 2006. When translated into an annual cost of therapy, these trends have led to an average cost that is more than 3 times higher than it was in 2006, the year that Medicare implemented Part D. Unfortunately, older adults are particularly vulnerable to these trends. Medicare Part D enrollees take an average of 4.5 prescriptions per month, and over 2/3 have 2 or more concurrent chronic illnesses. Thus, when AARP is talking about high prescription drug prices, we're often talking about costs that patients will face every year for the rest of their lives. AARP is very familiar with how high prescription drug prices affect older Americans. I regularly hear from our members who are desperately seeking help because they cannot afford their prescription drugs. These calls are not limited to just a few drugs and conditions. I've heard from people who need everything from eye drops to multiple sclerosis drugs. Unfortunately, many of these patients are ultimately forced to make trade-offs. Do you pay for rent, or do you simply go without, which ultimately increases healthcare costs down the road? AARP is also mindful that the problems created by high drug prices are not limited to people who are actually taking prescription drugs. Spending increases driven by high and growing drug prices will eventually affect all Americans in some way. They're passed along to everyone with health care coverage in the form of higher premiums, deductibles, and other forms of cost sharing. Further, increased costs for taxpayer-funded programs like Medicare and Medicaid will eventually affect all Americans in the form of higher taxes, cuts to public programs, or both. In other words, every single person in this room is already paying for these products. AARP has long supported a number of ways to address high drug prices, including secretarial negotiation. AARP also strongly supports policies that result in more price competition and lower costs for both beneficiaries and the federal government. This includes removing barriers and practices employed by brand-name drug companies that slow or prevent less expensive generics from entering the market. In addition, AARP strongly supported the recently enacted improvements to the Medicare Part D donut hole. Not only is the donut hole closing a year earlier, but drug manufacturers will be picking up a larger share of the costs in the coverage gap. Both of these changes will result in lower costs for Medicare beneficiaries with high prescription drug costs. It's estimated that beneficiaries will save $6.7 billion in both premiums and cost sharing between 2020 and 2027. Moreover, CBO found that this change will save the federal government nearly $12 billion over the next 10 years. While the drug industry is attempting to roll back these changes, AARP strongly believes that the new improvements must be maintained. In conclusion, the current prescription drug price trends are not sustainable. The current system is simply shifting costs onto patients and taxpayers, while drug companies remain free to set incredibly high prices and increase them anytime they want. Thoughtful efforts to help reduce prescription drug prices could save billions of dollars. More importantly, they will help ensure that all Americans have affordable access to the drugs they need to get and stay healthy. Thank you, and I look forward to your questions.
Thank you so much, Lee. We appreciate all the wonderful work that you're doing and that AARP is doing as well. I want to make sure and recognize Senator Joe Manchin, who is with us from West Virginia. Senator Manchin is leading our efforts to make sure that we continue to protect those with pre-existing conditions, which is each one of you are talking about that as well, which is the other important piece of this, to be able to have coverage and then to be able to afford your medicine. You know, I was thinking, regardless of whether it's Parkinson's or MS or diabetes or traditional high blood pressure or other challenges, we've made some wonderful improvements through research to be able to have medicine. My grandmother died of Parkinson's before there was any medication, and that's wonderful if you can afford it. Right? So medication now is a critical part of how we treat diseases, and that's a good thing, but only if it's affordable. And doctors and hospitals tell me that the reason that healthcare costs are going up, the uncontrollable piece for them is the cost of prescription drugs, which is another reason why we're here. Ms. Smith-Holt, I wanted to ask you a little bit more specifically about your story. And again, thank you for sharing Alex's story and being willing to share your family's tragedy. I understand you had an opportunity to meet with some of the executives at Eli Lilly and Company. And by the way, we have one of those executives who now is the Secretary of Health and Human Services for our country. But I wonder if you might just share with us what that meeting was like.
Sure. I had received the invite to actually attend a shareholders meeting. My intent when I went there was not to have my meeting with Mike Mason. The original plan was to do a press conference in front of Eli Lilly and attend the shareholder meeting. Several days prior to the shareholder meeting, Mike Mason, who is the VP of Eli Lilly, the U.S. sales division, had contacted me and asked for a private meeting. So I had agreed to meet with him. I thought at the time that the meeting went really well. I sat there with a picture of my son and I shared my story, and I had kind of drilled him about Eli Lilly's mission, vision, and values. It's clearly written on their website, what they stand for. He appeared to be really empathetic and really sympathetic, and he appeared to really listen to my story and to take it at heart. And he had vowed to take back my suggestions to his team and to stay in contact with me and to give my ideas some genuine thought. And I've yet to hear from him. They've recently come out with a helpline, a patient assistance program helpline. I was notified the day of the release of this, their press release, so I was given no advance notice. He made it appear when we were at the meeting that he would value my input on future, programs or plans that they had made or were planning to make, or work with advocates in general to come up with a plan that would service more than just their helpline. Never got that. I've had no communication from him whatsoever. Our meeting was in May. he sent me away with not even his business card. So, I mean, his PR person has followed up with me twice. Once was to tell me that my cell phone number got released on Facebook, and the second time was to tell me that the helpline had been released in that day.
If he was here today, what would you like to say to him?
I would ask him, you know, are you a man of your word? He certainly doesn't appear to be at this point. He seems to, it appeared to me that, you know, he was placating me. You know, here I am, a mother with a sob story, and he listened to me, and he made me feel like, you know, my son was important, and that the price of insulin is important, and that he understood that. I don't feel that way anymore, and just because of his lack of genuineness, the not following up, the not follow through, kind of crushes me.
You know, one of there are a number of things that we're looking at that our members, our Democratic members, are advocating, all of which lower the prices on prescription drugs. One of the things that I've been involved in is, as a border state of Michigan, we have a number of us as border states. We have a bridge called the Ambassador Bridge. On one side of the bridge, Eli Lilly U.S. sells insulin. On the other side of the bridge, Eli Lilly Canada sells insulin, same insulin,
Yeah.
FDA approved, safe, and so on. They have argued, lobbied Eli Lilly U.S. That it's not safe to re-import prescription drugs. I've asked them if they are saying that Eli Lilly Canada is not safe in their insulin. But we know we could drop prescription drug prices 40, 50% when I've taken busloads of seniors across the bridge and been able to drop the prices. And so when we think of insulin, I immediately think of what we could be doing if both sides of the bridge had the same pricing on safe, affordable
Absolutely.
medicine. Mr. Jones, I wanted to ask you, a very compelling story, unbelievable to be at your age, to have that diagnosis. I can only imagine what that felt like. But what would it mean to you if you couldn't afford the prescription drugs that you are able to take?
You know, I've been very fortunate because of my Marshall University education to work.
Hey, all right.
To work for good-sized companies that have great health insurance. But if I didn't have that advantage, you know, my disease progression would be totally different. I have friends who were diagnosed with multiple sclerosis the exact same month that I was, and although I go to my neurologist and they say, we can't tell the difference between you and a normal person, they are in complex wheelchairs. Mm-hmm. They can't walk, they can't, they've had to switch jobs. I have a friend who was a physicist and he worked on MRI machines, and now he's wheelchair bound and had to go back to school and get another vocation. So, you know, for me, if I did not have access to drugs, who knows what I would be able to do. And I tell you, you know, last year, actually a year ago this week, I was able to leave the corporate world and start my own non-medical home care firm. But the biggest obstacle that I faced was, if I leave the corporate world, how am I going to be able to have health insurance? And how am I going to be able to afford my medications, right? And it's my belief that health insurance costs so much because a huge portion of that goes to paying for prescription drugs, you know? And I talked about my daughter in my story, but literally a couple of years ago, I was able to coach her basketball team because I got on those disease-modifying therapies early, and I adhered to my medication regimen, and I have health insurance so I can go to my appointments every 6 months, get an MRI every 6 months, and have my drug land on my doorstep clockwork. But there are a lot of people who don't have that advantage, right? And we talk about having choice. There's been an explosion of MS drugs that have come to the market. One of them, the one that I started taking originally, was an injectable that made me feel like I had the flu for literally 2 days out of the month. There were a lot of people who would not take that drug. They would rather be sick and have their MS progress rather than take the drug. Now, if your insurance coverage doesn't cover the oral therapies, you're gonna continue to let yourself be sick, let your disease progress, irreversible damage to your nervous system, and when there's a perfectly acceptable oral therapy out there right now that maybe your insurance company doesn't deem like they want to include it in their package, right? So it's huge.
Thank you very much. Senator Wyden.
Thank you, Senator Stabenow. All of you were excellent. I want to start with you, Mr. Panagidis, because I think what you showed today is that health care is the great equalizer. Here you are, as I understand it from Senator Van Hollen, you are an accomplished individual, you worked hard, you worked for a variety of different companies, and you were successful. That's the American dream. And then when you got sick and got Parkinson's, your health care costs went into the stratosphere, and now you're having to make sacrifices, and even with the sacrifices, it's hard to get by. My question to you, and then I'm going to go to you, Ms. Purvis, is I think that our legislation to put a cap on out-of-pocket expenses for someone like yourself who planned and always did the responsible thing, I think something like that would be of real help to you. Am I right about that?
Thank you, Senator. Yes, indeed. And you're very right. We did everything right. We have all kinds of coverage, and yet we have problems. In fact, I made an estimate that my wife and myself, the total cost for our coverage, premiums, plus what we pay for drugs, comes to $23,000 a year. So the cost, and also the premiums are high because the price of drugs are high.
Right.
And it's a vicious circle. So by all means.
Good. And Ms. Purvis, essentially, most private plans in America already have a cap on people's out-of-pocket expenses. And it's the government that's being a laggard here. Is it your view that Part D would really be improved with something along the lines of our Price RX, our RX Cap Act?
We are certainly well aware of the challenges facing Medicare Part D enrollees. There are some Part D enrollees, just based on the vagaries of the benefit, who are being asked to pay $10,000 per year. And if you think back to what I mentioned in my testimony about the median income, they're roughly half of their income for Part D costs alone. So yes, there definitely needs to be something done to help improve for them. On the other hand, we're also very mindful that when you cap out-of-pocket costs, there are some downstream effects that you have to be cognizant of, in the sense that when you hold, unfortunately, drug manufacturers, you hold down in one place, they can pop up in another. So we want to make sure that out-of-pocket costs, if they are held down, are done in conjunction with efforts to actually meaningfully reduce the prices as well.
Your point is a fair one, and that's why we think it's part, in effect, of a triangle, negotiating power and transparency and the Spike Act to hold down costs and the like. So, fair point. Let me get your take on where things are for this year. So, after the president is elected, then President-elect Trump said drug companies were getting away with murder, and people thought there were going to be some big changes. Then he went in the Rose Garden trying to make the case for his plan. But as you've heard me say, my view is it was mostly PR and choreography rather than a substance. And the prices are still high, and that's why we're hearing from your associates here on the panel, from the witnesses. So Here's an objective question, because I don't want to, you all are charitable status, and I don't want to put you in a bad way. Since the President and Secretary Azar have been making these statements, what are, in your view, what are the major changes that actually have taken place that would hold down costs for people in this room? I haven't been able to find any major changes, but that's why we have you here. You're an expert in the field. By the way, I've enjoyed working with AARP since the days when I was head of the Great Panthers, so we've appreciated the relationship and the like. What, in your view, are the major changes that really help the people in this room?
I think one of the challenges in evaluating what has happened so far is a lot of it is to be determined. There are a lot of details that are outstanding. So while we very much welcome the idea of starting that conversation and putting some ideas on the table and starting to work towards implementing those ideas, it's very hard, at least at this point, because a lot of them are fairly long-term and do require a little bit more detail before they can be implemented. It's very hard to say whether there's been a meaningful impact for consumers. I can say that we have not heard from our members that prices have dropped.
You have not heard from your members?
That's correct.
Okay, so you juxtapose what Ms. Purvis has said with what the President talked about, how there were going to be all these price freezes and relief and the like. Pretty big gap between the oratory of the President-elect and then the President and what Ms. Purvis, who, based on my experience with AARP, is very knowledgeable in this field, pretty striking. So I thank you, Senator Stabenow. I'm going to have to run, but as we have seen with the Finance Subcommittee on Health, we are in good hands with you. And I thank you for your leadership, Senator Smith, Senator Durbin, Senator Blumenthal, and the cast of colleagues keeps growing. Senator Manchin,
absolutely. Thank you so much, Senator Wyden, for your leadership. But we have been joined by Senator Richard Blumenthal from Connecticut, so we thank you very much for being here with us. Senator Smith.
Thank you very much, Madam Chair. Ms. Smith-Holt, I'd like to follow up on something that you raised. And this is actually something that you and I'm thinking about your conversation with the executive from Eli Lilly and something that my mother often said to me, which was when I was explaining, she said, "Actions speak louder than words, Tina." And so this brings me to my question. You and I have talked about this. When your son was 26 and he went off of your insurance and he was needing to pay for his own insurance, he was working as a restaurant manager. Is that right?
Correct.
Yeah. And how about when he was thinking about trying to figure out how to pay for his insulin, about how much of his income was that going to cost him?
So if he would have purchased the Marketplace insurance plan, it would have been $450 a month plus a $7,600 deductible. So we figure with his salary and his monthly premium and paying out of pocket the $1,300 until he met his deductible, 80% of his wages for the first at least 6 months would have went towards nothing but prescriptions.
Yeah. 80% of his wages.
And he made close to $40,000 a year.
Yeah. So he's a young guy, he's getting going, and he has a good job.
Right.
And so I just have to point out here, so between 2010 and 2015, Eli Lilly increased the price of one of its insulin products by 325%. And at the same time, the 5 highest ranking Eli Lilly executives, not sure whether it's one that you spoke with, saw the value of their compensation packages, their overall compensation packages, stock and stock options and salary increase. In 2014, the CEO's salary pay was $14.4 million. And the president of Eli Lilly Diabetes was making $3.9 million. So, as my mother says, actions speak louder than words. And this is one of the reasons why I introduced a bill that would require the big pharma companies to tell us what they did with the stock big stock windfall buyback, which they got thanks to the Republican tax plan, because I don't think they were using it to lower insulin prices if they were Eli Lilly.
I think when I talked to you the last time, we had talked about some statistics that they had shared at the stockholder or the shareholder meeting. And at that time, it was in May, so it was shortly after that whole tax issue that they were getting, their tax money or whatever. They had just laid off 10% of their employees. So,
Yeah.
I mean, they had just gotten this big tax break, and yet they're laying off their low-level employees. And right now, I think the last I heard was the current vice president is clocking in like $40,000 a day for his.
So the spirit of this is why I think many of us on this panel and I have been working on trying to bring more transparency to what is happening with the stock buyback and also what is happening with prices and what is behind it. And let me just, in the short time I have left, I'd really be eager to hear from others on the panel if kind of what your take is on this idea of bringing more openness to how drug prices are set as one mechanism for trying to trying to shine a light on what's happening here with these anti-competitive companies charging whatever the market will bear and saying, oh, well, we need to do it for innovation. Does anybody want to comment on that transparent, Ms. Purvis?
Oh, absolutely. Increased transparency for drug pricing is something that we are strongly supportive. It is very difficult for us to push back on drug manufacturer arguments that money is needed for research and development or other activities without actually understanding exactly what they are spending their money on.
Like marketing, for example.
Exactly. Right now, all we really have to go on is a $2.6 billion number that came from an industry-funded organization, and we really don't know what's involved in that number. We can't replicate it. We know that roughly half of it came from the costs associated with not investing that money. I don't know if we want that included in the number being used to describe how much it costs to develop drugs. So increased transparency is something that would be incredibly helpful to be able to respond to that type of pushback.
Thank you very much. Madam Chair, I think I'm about out of time, so I'm going to cede back my 20 seconds. But I really appreciate so much you all being here to talk with us. Thank you.
Important questions. Thank you so much. Senator Durbin.
Thanks. First question to Mr. Jones. How is your daughter's jump shot?
Well, as much as I would have liked her to be a star athlete, she is more of she's a woman who likes technology. So her dream is to be a coder and a YouTuber.
Good.
So
that's good too. A question I would ask of everyone here that I already know the answer of: has you ever seen a drug ad on television? If the answer is no, you don't own a television. Because the average American sees 9 of these ads a day. The industry spends $6 billion a year on direct-to-consumer advertising. There's only one other country in the world that allows this, New Zealand. And the obvious question is, why do they spend all that money? Well, we're talking here about people needing drugs that are desperate for the drugs, and they're very expensive. But what the drug companies are doing is creating demand for drugs by educating us. The most highly publicized and most widely filled prescription drug in the United States of America is Humira. Humira. Humira was designed for rheumatoid arthritis, but they found that it also cured some forms of psoriasis, the little red patch on your elbow, which can be worse in some cases. What most people don't know is that the monthly cost of Humira ranges between $5,000 and $6,000. So for psoriasis, it doesn't make a lot of sense unless it's a very severe case. AARP is supporting an amendment which is pending on the floor of the Senate today, and the amendment would require pharma to disclose the prices on their drug ads on television. We're trying to get it passed. Thank you, AARP, for supporting it, and the American Medical Association, and 76% of the American people. And the reason is to shame them if they have to disclose these prices and their increase in prices, for goodness sakes. I don't know if it'll work. It certainly has, was his name Schrelke? That miserable bum who bought the company and then kited the cost on a pharmaceutical drug. That is clearly one of the things we need to do. And one of the points I want to make for the record, between 2010 and 2016, some 200 new drugs came on the market. Thank you. We're so glad they did. Every single one of them started with research at the National Institutes of Health, paid for by the taxpayers of America, government research, which started these pharmaceutical companies on the path to profits. So asking them to come back and help Americans in the process, I don't think is an unreasonable request. Thank you all for your testimony. I see some of my other colleagues, and I know we all have pretty busy schedules. Ms. Smith-Holt, I'm sorry. What a sad story. It breaks my heart to hear you tell that story, what you've been through. Mr. Jones, I'm glad you're doing well. Hope you can continue that. Mr. Panagidis, when I heard you speak, I thought I'm in a restaurant in Chicago. So many people from your homeland have started so many great restaurants.
And the Greek food was good.
Oh, it was always good. It's always good. Mr. Glazer, thanks. We've got to make sure that Medicare is strong. And those who want to fight and cut Medicare are in for a fight. Thank you very much.
Thank you so much, Senator Durbin, great leader of our caucus. So, Senator Joe Manchin from West Virginia.
Thank you, Madam Chairman, and to all of you, thank you so much for being here, and your testimonies are so well appreciated. And to Mr. Jones, you have attained quite a bit in your education, and we know that, yes, son of Marshall, he is a son of Marshall. And it's a great school, and a lot of culture there, and a lot of history. To all of you, you know, I understand that we're the only country in the world that prices drugs the way we do. I think Debbie was saying she can cross the bridge from Michigan to Canada and get the same drug. Do any of have you all, especially you all have the resources, AARP, Ms. Purvis, to tell the country why? Why are we allowing PBMs? Why are we allowing distributors? Why are we allowing third parties to jump and make all the profit? You know, I want to blame the pharmaceutical prices are way too high, and they're all overpriced. I'm the first to tell you that. But why do we allow so many people in between before manufacturer to the end user? Why are we allowing that, and why aren't you all speaking out on that? Why aren't you educating the public? Why don't you tell us why there's a difference of how the government prices brand name versus generics? Why are you all not raising holy cane that we can't go out and for Medicare and really compete for generics, much lower price? Who are we protecting and why are we protecting them? I'm saying I'm not singling you, but I know your organization is so heavily relied upon, and you all have the wherewithals and you have the voice to speak out on this and change it.
Well, one thing I would like to bring to your attention is just last year we did a bulletin that was our most widely read periodical that focused entirely on what you're talking about, actually, where we discussed prescription drug pricing, why there are problems, where the problems are, and trying to educate people to help them understand the problem is incredibly complicated. And that
but why don't we advocate for the government to do the negotiation? Why do we allow PBMs, three of the largest corporations in America that don't make one thing, they don't absolutely market at all, but they skim off of every pharmaceutical drug sold to each one of us day in and day out, and they're the largest profitable publicly shared companies, and we allowed this to happen.
It is definitely...
I mean, you all know about it, right?
Absolutely.
Did any of you all know what I just said about PBMs and the people in between making all the money? And, I mean, pharmaceuticals are making a heck of a lot of money, too. Trust me, too much. But then we just add insult to injury. And then in my little state, can you believe I've got one little town, and it's Kermit, West Virginia. Kermit, West Virginia has 392 people. They've sold over, I think it was 4 or 5 million opiate pills in a period of 2 years. Can you imagine allowing that to happen? DA did nothing, okay? And then FDA allows all these products to keep coming to market. And it's, you know, someone has got to shed light upon this, and we've got to step forward, and it's our responsibility here. But we can't do it unless we have you all being our eyes and ears and mouthpiece. Because I can tell you, you can watch these halls around here and things happen, okay? They don't happen when you all go back home and go to the voting booth and basically start speaking up and making people hold them accountable at town halls if they'll show up and find out. But I can tell you the pricing, I never knew this until I started looking into it. Why do we allow everybody? And why isn't the government negotiating for our best interest? And all we have to do is, why don't we just model off of Canada? Why can Canada sell so cheap? Why does the UK sell so cheap? Why is Europe and all these? If you're, God rest your son, I'm so sorry. If he'd have lived in another country, he'd still be here with us. And it's just, it's, you know, and Mr. Jones, you know, God give you the ability and the talent to take care of yourself at a level. Think of all the friends you've got, or people that aren't qualified to do what you're able to do. They wouldn't be here. And you said half of them are in wheelchairs and can't even function. And to all of you, I mean, our heart goes out, but we need help. We really need help. We need your help. And we're willing to take on a big fight, but government's got to step forward. Has this administration, any of you all seen, and I know that Senator Wyden spoke about it briefly, have you all seen this administration? I mean, they're talking about it, and I'm anxious, and I was excited to hear President talk about they're too high. We're going to take these companies on. Have you seen any changes within the last year and a half? No. Nothing. No one. No one stepped forward. No one's holding them accountable.
If I may say something, I
Please.
think that there's an issue with physicians too. We overlook the physicians because they overscribe tremendously. I come from a family of doctors, and I hear that all the time. They continue to prescribe medication after medication after medication when it's not necessary in many cases.
Anybody else have any comments? Mr. Pangelis?
Just to add the importance of transparency. As you know, the pharma believes in competition, presumably, in ideologically competition. But the competition is not there because we don't know. The transparency is so important. The market is not functioning, even if we believe that the market can do it, which it doesn't do it, of course, without regulation. And we hope that people like you can help us do that. Thank you.
If you ever get a chance, read the lawsuit against Purdue Pharma with OxyContin that the United States brought against him and how it was settled. If you haven't gotten it, get it. It'll open your eyes and scare the living bejesus out of you. Thank you all.
Well, thank you, Senator Manchin. And as you know, we are here because we know this has got to change, and we are committed to making it change. And we do need your voices, and we're so grateful you are all here today, as well as people that are watching and listening to this conversation. We do need that help and pushback in order to be able to get done what needs to get done. But it's got to get done. Things have got to change. This is wrong. This is just simply wrong in our country. Senator Blumenthal.
Thanks. I was just telling Senator Manchin, my colleague and friend, that as Attorney General of the state of Connecticut, I sued Purdue Pharma for its misrepresentation at the time, and there were criminal indictments as well as civil lawsuit, because it misrepresented to the people of West Virginia, as well as Connecticut and the whole country, that OxyContin is not addictive. That's what they told the American people at the time. They literally said not addictive. And the overprescription of drugs, you're right, Mr. Glazer, the lack of competition, absolutely right. And as you say, and I was struck by this part of your testimony, Ms. Purvis, and I'm quoting, "Meanwhile, the research pipeline is full of products like orphan drugs, biologics, and personalized medicines that do not face much competition and will undoubtedly command even higher prices in what appears to be a never-ending race to the top." End quote. The only way I differ with that statement is, in my view, it's a race to the bottom of poorer practices, less access, and affordability for the American people. So I want to come back to this point about the need for more competition and for more choices, which right now is stymied by the misuse of patents, the agreements that are struck to prevent generics from coming to the market, but also the lack of negotiation for Medicare prices, which is one clear partial solution, only a partial solution. And I wonder if you could tell me, in your view, Ms. Purvis, what is the reason that we haven't gone to negotiation of Medicare prices, which AARP commendably has long advocated?
Yeah, AARP is an extremely strong supporter of secretarial negotiation. There are a lot of factors playing into the pushback against that idea. Very powerful, frankly, interests. First of all, the drug industry obviously does not want Medicare, the gorilla in the room, coming in and negotiating prices. And it would represent a bit of a change in the sense that PBMs would not be necessarily involved in that type of negotiation, so they have a stake in it as well. There also have been some efforts to, frankly, scare beneficiaries about what negotiation would look like. The drug industry has been very effective at messaging and saying that it means that they would no longer have access to the drugs that they need, which obviously is not what anyone intends by this. They simply want to negotiate prices. But that's a very effective message, and I think that has played a role as well.
Do you find your members are affected by that message? Are you hearing that back from them?
No, our members are incredibly supportive of negotiation. Approval is around 90%, and that's not limited to our members. That is across the board, across the spectrum. This is an idea that really resonates with people because it is, frankly, common sense.
And Mr. Panagrides, I wonder if you could comment on the idea of competition, what you see as the main obstacles to achieving more competition. You raised it very well.
I'm an economist by profession, and one of the things you learn is how important is competition and the markets to function properly. But all the assumptions we make for that are not present in the case of the pharmaceutical industry. Information is not there, the consumer is not informed. In effect, you have an oligopoly, few powerful suppliers. It's my judgment that without regulation that sets the conditions that make the market function properly, the industry will not do it, and we know this. The history tells us that. If we look at countries like Canada, as you mentioned, we see that it is the health is a public good. That means, in economic terms, if my neighbor is sick, it's not good for me. Something that we call externalist economics in the theory of economics. So in the very basics of the market are not present in this case. We need regulation, we need information, and to make sure that the real the cost itself is not so exaggerated because the market is so oligopolistic. And for that, we need the government. We need people like you to do that. Thank you.
Thank you very much. My time has expired. I thank you all for being here today.
Thank you very much. And we have been joined by Senator Ben Cardin, also from Maryland. Mr. Panagrides, you have the distinction of having both of your United States senators here today. And we will now turn to Senator Cardin, one of our great advocates on health care.
Well, first, to Senator Stabenow, thank you for bringing this issue to the attention of the United States Senate. We should be having our committee hearings focusing on the testimonies that were given here today. And the Republican leadership will not bring this issue up in the regular committee process. So I thank Senator Stabenow for her leadership to give us an opportunity and the American people an opportunity to understand this is not as complicated as the pharmaceutical industry would like you to believe. Mr. Panagrides, I think you said it best, the economics of this. It's not about denying these drugs because of a negotiated price. We take a look at what Americans pay for the exact same drugs that are purchased in industrial nations around the world, and you see it's 2 to 3 times more. And then you see the growth rate of pricing for pharmaceutical drugs in America, and you see it growing at a much faster rate, almost a multiplier rate of medical inflation. And then lastly, we talk about the high cost of healthcare today, and you start to take a look at what is generating that high cost. We're paying 2 to 3 times on drugs, so how much are drugs? Well, they hide that number a little bit because it's in a lot of different rates, because it's not just what is paid for under Medicare Part D, or because it's included in a lot of the institutional reimbursement rates. So we did a study in Maryland, Senator Stabenow. It's now about 25% of the healthcare costs is in medicines. So this is a big number. And what we're finding is that there's shortages of drugs, that the access issue is being complicated because we don't have an organized market. If we had an organized market, access to drugs would actually be easier to acquire rather than more difficult. So every other industrial nation uses its purchasing power, and that's how they determine the price, except the United States, which by law we're prohibited from being able to do. And that's why, one of our suggestions is to allow for competitive pricing. And I apologize for not being here a little bit earlier. I had some committee hearings in some other committees. But I think that's the key. I understand the frustration of people having to go to Canada to get their prescriptions filled because it's the only way they can afford it. But they should be able to buy their drugs here in America at competitive pricing, and that's our responsibility to set up a mechanism where we can have fair competition for price. And then as far as the availability of drugs, we have programs to do that today, but those programs need to focus on the abuses that we see in the pharmaceutical industry that are creating shortages with an intent on profit rather than on the availability to the consumers of this country. So to me, this is an issue that is urgent today, but if we don't take action, it's going to be even worse moving forward. And I read your stories. I know tragic circumstances that have occurred. I know the tough decisions. I remember very well as I did town hall meetings on the need for more comprehensive coverage, so many people telling me that they literally had to make a decision at the pharmacy whether they were going to leave their drugs at the counter, people splitting pills when they're not supposed to split pills, all that. And it's now on the increase in America. So I just really wanted to come by to thank you for putting a face on the issue. We hear statistics, but you all put a face on it. And we can identify with that. And I know it's painful, but it's important that this story be told. And I wanted to come by and let you know that we're listening. And we're going to take this message to the American people, and we're going to win this issue. Because I think Americans understand it's their access to health care that's at risk. And we've got to make sure that we have competitive pricing. We have to make sure that we have the availability of drugs, that the gouging issues are dealt with. There's a series of proposals that we have in our caucus that are strongly supported by the members of our caucus. Your presence today have made it easier for us to deal with this issue. So thank you for being here.
Thank you very, very much. I know that Senator Merkley is going to be joining us in a moment as well from Oregon. So I want to ask Mr. Glazer, go back to where we started in terms of you're talking about Medicare and what we call the donut hole. And as we know, Medicare Part D was passed and with coverage, but then there's a gap in coverage. And then if you have high enough expenses, then you get help again. And so we have pushed very hard in our caucus, we as Democrats, to close that gap and are on the way to doing that at this point. But we also know that in a few weeks, there's a court case in Texas where we've seen 20 Republican governors and attorney generals trying to completely overturn the Affordable Care Act, which would create the gap again. So I wondered if you could just speak to what reopening that gap, the donut hole, would mean to you, and what you hear from others that you work with, other seniors and people with disabilities. What would opening that up and creating that donut hole gap again mean?
I think it would mean a lot more difficulty to those seniors that are, in the donut hole and falling into it and that kind of thing. It's, you have to spend so much money to get out of the donut hole before you get the catastrophic coverage that I think it's just an ongoing problem. It was probably original fallacy in the law in the first place. But I think it's just something that you just got to keep working on, like so many things that we do.
Well, we're hoping that that court case goes in the
Yes.
direction of actually supporting seniors in America and those on everyone on Medicare to be able to keep that gap closed. And you're right; it should never have been written that way in the first place.
Yeah, it was an attempt to save money at the time.
Yes, yeah, but thank you very much. We've been joined by Senator Jeff Merkley, so we now have the second Oregon senator. So 2 senators from Oregon have been here, 2 senators from Maryland have been here, and we really appreciate that you are here. We know, as with everyone juggling many things today, and we're so appreciative that you're able to be here. This has been a wonderful panel of witnesses sharing their personal stories, and Ms. Purvis from AARP has given us a lot of very important information. So, welcome. Yes.
You ready for me?
I am ready for you. Yes.
Well, thank you all for coming in and testifying because this is such an important issue to Americans. And I'm glad to hear my colleague was here from Oregon, Ron Wyden. We hold a lot of town halls. Both Senator Wyden and I hold separately 36 town halls a year, 1 in each county in Oregon, where people can ask anything they want. And you can imagine how many times an individual stands up and says, what I want to know is, why am I going bankrupt buying a drug here in America that I could buy for a fraction of that price in Canada or Europe? Why do Americans have to pay more than Canadians? Why do Americans pay more than Europeans? And that's a great question. In fact, so often the drugs are developed on the foundation of research that we have paid for through the National Institute of Health or through another mechanism. So it seems like, if anything, those drugs should be offered for less in the United States than in Canada or Europe. So what's the answer here? What's the rationale for why Americans pay such higher prices, sometimes 2 to 6 times higher prices than citizens in other developed countries? And Ms. Purvis, I don't know if you want to address that or not. It'd be helpful.
I actually have a very simple answer to that question because I get it a lot. And the answer is purely because drug companies can. We have nothing in our healthcare system that stops them from setting very high prices and increasing them anytime they want. And we're seeing the results of that.
So the other countries say, let's use our marketing clout because we're making decisions for prices for our citizens. Let's make sure our citizens get a fair deal. But in America, we're not using our power to get citizens a fair deal. Is that a fair way to put it?
I believe so. I think that's part of the reason that everyone is so interested in secretarial negotiation allowing Medicare, because at least then you're representing tens of millions of Medicare beneficiaries. But the rest of the system is very fragmented, and you're not going to have the same level of negotiating power that you would if you were negotiating on behalf of an entire country.
So as soon as I think we start to have a conversation about operating with the same kind of instruments of leverage that other countries use, we hear cries and concerns like, wait, you're going to wipe out innovation in America. Is that a real concern? What's your thought on that?
I think that question would be much easier to answer with transparency, which is something we've discussed in the sense of having the information to know what drug companies are spending on R&D, how much they really are innovating, getting a better idea of how much they're benefiting from taxpayer-funded research. I think that would go a long way in answering that question. There is just a general lack of information, so it makes it very hard for us to answer that right now.
Anybody want to weigh in on and no, you each. I apologize that I missed your testimony and your stories, but I just want to make sure I give anyone else a chance to weigh in on this question if you haven't already fully commented on it.
I think that taking over the House would be a good start.
Thank you. On a host of issues, I might add. Thank you.
Thank you very much, but you didn't say the Senate. Well, thank you. Thank you, Senator Murphy, very much. As we bring this to a close, let me again thank you. And I do want to underscore one point. We've talked a lot about something very straightforward. The colleagues have all mentioned, and I've mentioned, and you've talked about, which is negotiation, Medicare negotiating best price. Just want to underscore the fact that the Veterans Administration does negotiate on behalf of veterans. They already negotiate. The world didn't end, but our veterans get roughly 40% discount as a result of negotiation. So this is something that is done. I'm glad it's done for our veterans, and it should be done for everyone that is on Medicare. I would also note that we know there is an opioid crisis, and the president put together a commission to focus on that. They came back with a series of recommendations. One I thought was very, very important, and that was that given the crisis on the opioid addiction, that the government should use its purchasing power to get the best price on naloxone, which I had mentioned earlier. Naloxone, which as late as 2005 was sold for $1 a vial, is now greatly increased in price. And the President's Commission recommended negotiation on naloxone. And so that's something that I've been urging in many settings, including writing to the President and so on. This is something that could be done regarding the opioid crisis right now. That was recommended by his commission, which I thought was very important. Again, let me say, we know how serious this is. This is wrong, what's happening. It's just plain wrong. Putting power and profits of people on the most basic set of needs, which is life-saving medicine, is just wrong. So thank you for being here. My colleagues who've joined us and others who weren't able to join us today feel as strongly as I do about this. And this can be fixed. It has to have people who want to fix it, who want to stand up to the drug company lobbyists and the special interests and say, no, we're not going to continue this rigged system. We're going to fix it so people can afford their medicine in our great country. So thank you again, and to everyone watching us on Facebook Live. Please get engaged in this. Share your stories with us. I know this is something for me on my website we've been doing for a number of years, gaining the stories that I can then share on the floor, and I know my colleagues feel the same way as well. Together, we can fix this, and we've got to do it. So thank you very much. This meeting is adjourned.